So I am Bundorf. I am a professor here at Duke. I am a health economist, and I am doing double duty as chair of our session and the first presenter in our session. So in this session, we decided we're going to have the three presentations as usual and try to have questions after each of the presentations, right? Structure it that way. So that's how we'll proceed. So okay, so I'm going to switch out of the welcome role and the presenter role. Yeah. Again, I'm Pete Bundorf. I'm really pleased to be here to talk about some research I've been doing with many of my colleagues at work here at Duke, Donna Kaufman, Mark McClellan, Courtney Van Hopen. We've had various different data analysts on the project, Abby Jury, Susan Shee, and a research assistant, Ruby Ojo. This talk is basically I think Igor was really interested in Medicaid claims, right? And how to think about, as people are approaching the age of Medicare eligibility, what their health status looks like, presence of chronic conditions, disparities in those conditions, thinking about how they're going to progress into the Medicare program and what their health status will be. So he invited me to talk about this work. This work is a project we started soon after the pandemic began when I moved to Duke, looking at healthcare use and outcomes among older adults enrolled in North Carolina Medicaid and not Medicare due to disability during the COVID-19 pandemic. So what I'm going to do today is talk a little bit about North Carolina Medicaid claims in the context of the using existing data sources theme of this conference. Talk a little bit about disparities among the population that we're looking at, and also show you some results on the impact of the pandemic on mortality, differences by race, as well as some results on how it affected healthcare use. Okay, so I'd like to acknowledge funding from NIA through NBER and also Okay, so this is focused on North Carolina. One of the reasons I was interested in doing this project is I had not yet used Medicaid claims, health insurance claims from a state-based Medicaid program. And Duke and actually many other researchers and other groups around the country have access to state-specific Medicaid claims, right? And it's a really rich resource for folks to use. So I thought I'd give a little bit of background here. We've talked a lot about Medicare. Medicare is obviously public insurance for people 65 and older, and some groups of folks who are disabled in the U.S. covers a lot of people, obviously very important for the study of ADRD. The Medicaid programs are a little bit more complicated. They tend to focus on low-income folks. They tend to be more state administered rather than federally administered. That means if you see one Medicaid program, you've probably seen one Medicaid program. So there's a lot of heterogeneity across the U.S. In North Carolina, we have a very kind of proactive and innovative Medicaid program. Here is our Medicaid dashboard for North Carolina. That's where you put all these data from. So if you're interested in any of these statistics, you can access them stuff yourself through the Medicaid dashboard. The point here, so what I've given here is enrollment information by it's called program A category, or the type of eligibility for Medicaid. So traditionally Medicaid, people were eligible for Medicaid because they were low income and something else. They had some other Medicaid eligibility category, typically related to their health. That changed when Medicaid expansion through the Affordable Care Act came, and med state programs expanded their Medicaid to cover many states expanded the Medicaid programs to cover all low-income individuals. So these are all the different program aid categories in North Carolina, and they are very heterogeneous and very different groups of people. So you can see infants and children and kids who are roughly eligible due to low income represent about 1 million people in North Carolina. Today, I'm going to focus on people who are eligible for Medicaid in North Carolina due to disability. In 2024, there were close to 300,000 of those folks. Some people are low income and aged. In 2024, there are about 155,000 of those people. These folks do not have Medicare as well. These are Medicaid only. And then there's obviously a much larger population of people in North Carolina who have Medicaid and Medicare. Okay, so very complex and very heterogeneous group of people, a subset of people who are aged and disabled who are probably closer to the types of populations folks work on in the context of ABRD. This just, again, from the North Carolina Medicaid dashboard, gives the distribution of the Medicaid population by age. As you can see, lots of kids, but then a decent population of folks who are older. So North Carolina, so states are very different in the extent to which they gather information on race and ethnicity in Medicaid. North Carolina has good data, and generally, it's never as good as we want it to be, but they collect data, I should say, on race and ethnicity among people at the time they enroll in Medicaid and make that available through claims data. So this is the distribution of everyone enrolled in Medicaid by race and ethnicity. There are relatively very low proportion of people who are unreported. Ethnicity, same thing. Pretty low proportion of people who were unreported. So moving forward, the data on race and ethnicity are fairly complete. In North Carolina, and during the period I'm going to study, the data on ethnicity is less complete. So we'll see that as we go along. Okay, so in this particular study, we focused on people who were 45 to 64, who were eligible for Medicaid in January of 2020 due to disability. So that's a pretty, we're taking kind of a little bit of a narrow group and making it even more narrow. And why were we so interested in this group? Well, if you kind of maybe roll back in a slightly unpleasant way to the very beginning of the pandemic, you might remember that health, we were obviously very worried about infectious disease. We were also worried about this reduction in healthcare use at the very beginning of the pandemic. So even people who were not exposed to COVID or not worried about having COVID were not going to see their doctor or their doctor did not want to see them, or hospitals were delaying procedures because we were worried about the spread of COVID. So these folks are very interesting because they were in some ways they couldn't win either way, right? So they were very worried about contracting COVID because many people in this population, as we'll see, have various underlying chronic conditions, and all the evidence was saying outcomes are really poor for COVID for people with chronic conditions. On the flip side, these folks use a lot of medical care to manage their medical needs. So the idea of not accessing medical care when you need it was also potentially a large important barrier problem for them. Okay, so study design. Basically, what we're doing here is we have the cohort that we're interested in, the people who were exposed to the COVID pandemic in 2020. The way we set up the design is we identify people in the year prior to 2020, who meet our study criteria, and then we follow them out through 2020 because the COVID affected a lot of people. Everyone was kind of exposed. We look for our control group using prior years. So we have 2 prior years of claims. Or 2 prior years of cohorts that we use as control years. People we identify in 2018 and we follow them into 2019, and people we identify in 2017 and we follow them into 2018. The North Carolina Medicaid claims, at least those that do, go back to 2013, right? So if you're interested in following people over time, there's a relatively long time period. Okay, so I'll talk about 2 different things that we did with the claims. We basically looked at healthcare use in 2020, and then we looked at excess mortality in 2020. So for healthcare use, we're basically looking at monthly utilization for the COVID cohort relative to the 2019 and 2018 cohorts. We basically estimate linear models with individual level monthly utilization as the outcome. And that is a function of the cohort, the calendar month, and then the interaction of those 2 things. In all the models, we control for age, race, ethnicity, gender, and CCI, and the Charlson chronic condition indicators. We also control for clustering of the standard errors, because if you start thinking about the construction of my cohort, people are showing up in multiple years. Okay, we also do an exercise where we look at excess mortality. We're using very standard methods to do this. We're basically modeling the relationship between mortality and individual characteristics. Many of those you saw in that bullet above, using data from the 2018 and the 2019 cohorts. Then we calculate expected mortality in 2020 using the model based on the 2018 and the 2019 cohorts, and then we compare actual to expected mortality. In this exercise, we're going to differentiate by race, Black versus white, and between those with and without a COVID-19 diagnosis in 2020. One thing, if you've been following this literature, one thing that we're doing a little bit differently than many other studies that are differentiating, that are looking at COVID and non-COVID mortality, is they are often looking at cause of death. We don't actually have cause of death in our mortality data, but we do have information on whether you were diagnosed with COVID. And you might remember this is early in the pandemic. This is before you could really get diagnosed at home and have a self-test and not have it be reported in the data. Okay, descriptive statistics for our study sample. We have, by design, restricted it to people who were 45 to 64 in their analysis. In the analysis year, this refers to their identification year, and you can see the age distribution of the entire population, and the population identified as Black and the population identified as white. They're roughly similar. You can see, it's almost even split by gender, female versus male. And then when we get down to race, for this group of people, the distribution of the population is mostly Black or white. These are older adults in North Carolina, and we have relatively few folks in all these other racial categories. Although we collect information on them, we can't generate estimates on any of these groups because there are too few. So we restrict to either Black or white in our mortality analysis. Ethnicity, here's where I said the earlier data were missing. Then in the North Carolina Medicaid claims are more likely to have missing data for ethnicity. We find relatively little evidence of people reporting Hispanic ethnicity. So we basically don't now use by ethnicity. In this project, we're going to measure health status primarily using the Charlson Comorbidity Index. If we start down here looking at the differences by race, we can see when we actually take the indicators of the different conditions and weight them according to Charlson, we find that health status looks a little bit worse for Blacks than whites in this population. If we simply just count the number of Charlson indicators, it looks a little bit different, right? We find more coded conditions among whites than Blacks. Okay, so here's kind of a quick look at the implications of the pandemic for healthcare use. This is similar to other studies in the literature. This is basically saying what happened to hospital admissions. We normalized in January of 2020 relative to 2019. And in February, things were humming along as usual. But once we got to March, there was a pretty big dip in hospitalizations. They started to recover in June, and then we're a little bit lower for the rest of the year. When we look at ED visits, we see the same kind of pretty dramatic drop and less of a recovery through the rest of the year. If we look at office visits, things look a little bit noisier, but we again see that pretty dramatic reduction in the beginning of the year, and then it's kind of hovering, it's a noisy kind of hovering up and down for the rest of the year. Notably, this does include telehealth visits, right? So as folks know, that a lot of people switch to telehealth, and we see that in our data. Here is the use of telehealth. It went up dramatically and then went down, but then kind of stuck for the rest of the year. But the use of telehealth did not fully compensate, at least during this time period, for the early time period for the reduction in in-person visits. Okay, so what does the health status of this population look like? So basically what I've done here is just taken the Charlson indicators and plotted the proportion of the population with each of the indicators. So on average, The most prevalent condition as measured this way is depression, with about 37% of these folks identified as having depression, a relatively high rate of substance abuse disorders as well. If we look at diabetes, it's a little bit misleading because there's diabetes without complications. Diabetes with complications is a separate category, and if I add them together, I get about 48% of the population is coded as having diabetes. Okay, so this is the kind of order of conditions. This is a little bit messier, but what I've done here is looked at the black-white disparity in these conditions. So we're still ordered by the most prevalent to the least prevalent conditions. And, I guess when I squint at this, it's a little all over the place, right? And what do I mean by that? Technically, in some cases, we see higher rates of particular conditions like depression and, this chronic pulmonary disease among the white population than the Black population in this particular group. When we look at things like diabetes, we see higher rates of diabetes without or with complications among the Black population as opposed to the white population. Okay, so I'm going to jump to thinking about the mortality rate among this population during the pandemic. And this is just plotting the unadjusted mortality rate. So the mortality rate among the Black population was 27 deaths per thousand, and pretty constant between 2018 and 2019. The population is aging by roughly a year during in this time, right? So that explains that increase. The white population, pretty constant between 2017 and 2018. For both groups, mortality jumped, now surprisingly, during the pandemic. I think a little bit more surprising is that mortality rates were lower among this low-income population who are eligible for Medicaid due to disability, right? So this is a very specific and select population. Mortality rates are lower among Blacks than whites. When I control for all those chronic conditions that I showed you and age, I still get a pretty big kind of favorable mortality effect for Blacks relative to whites. But here you can see, there will be excess mortality among this group. Here I'm looking at the COVID diagnosis rate. So this is just the proportion of people in 2020 with each group that for whom I can find a COVID diagnosis. I find about a little over 5% of Blacks relative to 4% of whites had a COVID diagnosis during 2020. Here I'm looking at expected mortality, right? So I'm using that model from 2018 to 2019 to predict mortality for 2020. So you can think about that this is a measure of health status, essentially, what I expected mortality to be among this group. And these are, not surprisingly, based on what we're doing here is expected mortality is higher for whites than Blacks. When we look at folks diagnosed with COVID versus folks without COVID, we see that expected mortality is higher for both Blacks and whites among people with COVID than people without COVID. That's consistent with what we were seeing earlier and later in the pandemic, that people who had higher rates of chronic conditions were more likely to contract COVID. And that relationship is similar across the two groups. Okay, so this is reporting excess mortality in 2020. So now I'm thinking about the difference between actual and expected mortality. And I see higher rates of excess mortality among whites than Blacks. I guess I should say I see excess mortality in both groups. If I look at my estimates of 2 deaths per 100,000, 4.6 deaths, per 1,000, that is much lower than national estimates for adults 25 to 64 calculated from other studies. When I look at excess mortality among people with and without COVID, I should say people for whom I can see a COVID diagnosis in the claims, not surprisingly, I see higher excess mortality in both groups among those with and those without COVID, but both excess mortality, there should be confidence intervals here. I'm sorry about that. These are all, the black-white differences are all statistically significant. So I see higher expected mortality overall, and among people diagnosed with COVID and among people not diagnosed, who didn't have a COVID diagnosis in the claims, among whites relative to blacks, right? Okay, so summary of what we've been finding. We find a high prevalence of chronic conditions among people eligible for North Carolina Medicaid due to disability, age 45 to 64. From our talks yesterday, lots of these are important risk factors for thinking about subsequent ADRD diagnoses. I think I forgot to mention that in my, one of the diagnoses in the Charleston Index is dementia, and I think I have about 2% of people at this point, from 45 to 64 who actually had a diagnosis of dementia. We find disparities by race in the presence of chronic conditions, but it really varied a lot depending on which the direction, depended on which chronic condition we were looking at. We find mortality rates are higher among whites than blacks in this population prior to the pandemic. Consistent with other work, we find there's greater incidence of COVID-19 among blacks than whites. But expected mortality, people who had a COVID diagnosis were more likely to be characterized by having underlying chronic conditions. And then we find excess mortality both with and without COVID diagnoses. What we're doing here in the next stage of the project is thinking about how did those reductions in healthcare use that I talked about in the beginning of the presentation contribute to this excess mortality among the people who didn't have a diagnosis. Was that a potential? There are lots of things that could be driving that. Lack of access to medical care is one of them. And finally, we find excess mortality was greater among whites than blacks in this particular population in the beginning of the pandemic. Okay, I will now step into my role as chair and say thank you, Kate, and open the floor up to questions.
Yeah. So 45 to 64, that's a 20-year wide age group. Did you standardize or control for age to see if the mortality differences were due to differences in the age distribution within that 20-year age group?
So we have, when we calculate expected mortality, we're using, so these are, let's see. In that exercise I showed you, we can't tell, right? But we have estimated models in which we control for the presence of chronic conditions and age, look at differences between like the black-white differential, and neither the presence of chronic conditions nor the different age differences in age distribution of those two populations affects the favorable mortality, or explains the favorable mortality of the Black population. Is that what you're asking?
Now, I'm just trying to understand when you show the comparisons between the Black and the white populations, whether those comparisons do or do not control for the age differences between those populations.
No, when I look at the, we're thinking about within each of those groups, right? So I'm basically saying that, with the excess mortality is basically, so within each of these age groups, I'm kind of holding that age group constant, but there may be differences in the age. I haven't controlled for differences in age between the two groups, right? So I know that excess mortality is greater among whites than Blacks, given their age distribution. If you go back to the beginning slide and you look at the age distribution of the populations, they're actually not that different. They're actually pretty similar, right? So I don't think that's a huge effect. And when I estimate a model controlling for age, I still see a favorable effect. Igor, and then Lisa, please.
So, two quick questions. So, last year we discussed the hypothesis that maybe Alzheimer's disease disparity are generated due to this region diseases like diabetes and hypertension. So we have different prevalence, it goes to 65 and above, and generate the different, do you think that this can be, and from your point of view?
Yeah, so we certainly see a high rate of diabetes among these people who are becoming eligible for Medicare. And we see a differential in the prevalence of diabetes between Blacks and whites in this population. We didn't, hypertension is actually not in the Charleston set, right? So we didn't code that up, but we could look at that. Depression was another condition for which I learned yesterday was a precursor of ADRD. Interestingly, the differential in depression and diabetes high rates goes in different directions. Right. So
You think that COVID could change this picture somehow? COVID pandemic?
could COVID change this?
Yes.
That's a big question, Igor. Change this picture. I mean, there's yes, there's a mortality effect that we want to think about, right? So a different set of people are arriving at Medicare based on elevated rates of mortality prior to Medicare. And, I would actually lean on some clinical colleagues to think about maybe the interaction of COVID. I showed you that people diagnosed with COVID were more likely to have chronic conditions, right? So there might be some interesting interaction effects between COVID and chronic conditions as we arrive at the age of Medicare.
Generally, this is calculatable, yeah?
This is what?
Calculatable. And maybe we have to organize a working group between our workshop to check this in detail.
Yeah. So it would be super interesting to, this is a long conversation, but super interesting to start following people from Medicaid into Medicare, right? And look at how a longer trajectory of their health conditions are affecting ADRD diagnoses.
So just a thought, given the importance of social engagement and personality and ADRD risk, I just wondered if it would be something as explained as simply as Blacks have stronger cultural family support, family ties. I know in our rural area, the churches never really shut down, so, that was just a thought.
Yeah. So that is, yes. So the kind of the mystery of this project is, or the, a thing to really understand better is where does that favorable mortality result come from? And I mean, it's interesting that it existed prior to the pandemic, right? And then was, seemed somewhat protective during the pandemic, whatever that factor was. And that is one thing that people talk about are stronger community ties, right? That were protective in both of those situations. Yeah.
Great.
Yeah. But if we have any ideas on how I can really push that empirically in North Carolina, that would be